big verticalization for him. So it was only one choice to save him. Another example, the same one, and this girl is laying now in our hospital, so we left her at home, going here, and she's preparing for her further surgery. So you see the same situation, and a very huge kyphosis, and no conditions for closing of this bed sore. So we use this system of transpedicular and pelvic external fixator, and you see in dates that it's after applying, after 1 week you see granulations, and only 20 days for full closing of the wound of bed sore. So it's very, very good and safe way of treatment in these very complex patients. So the key points are that external fixation can be a very handy research tool. Remember this. But the main indications are high-risk spine surgery, and use it temporarily, be quick to replace it with internal fixation. And it is excellent in septic conditions. And Halor can be used alone in pediatric cervical conditions only. In other way, you must really very quickly replace it with internal fixation. So don't be afraid to combine, and in big field of spine surgery there is a little but very important space for external fixation, especially as a safe boat in very bad conditions and as an excellent research tool. So remember about this and you will be safe and free. And I want to show you that we have some different things, very interesting things in our institute. We have our journal, you can publish it there in Russian and English, and we have training courses. And in St. Petersburg it will be a Francophonic big congress and Assami Congress, Satellite Congress in St. Petersburg in May. So I want to invite everybody to this congress. And welcome to Elizarov Center to Russia. Thank you very much. I am ready for your questions.
Yeah, now any questions if you want, anybody? Yeah. Mike, please. So take the mic. Okay.
Thank you for your excellent talk. Something really innovative for us. Basic question, you used this and you said it gives good results in bed sores, the iliac and the transpedicular screws. I'm not very sure how. Could you just explain a bit more of how it helps in healing of bed sores?
Okay. So the main reason that these devices are very successful in treating of bed sore are creating very good conditions, first of all, for bed sore, because in these patients you see a very huge kyphosis, first of all, and not enough vascularization for tissue, and the compression of bones to skin and to soft tissue provides very big bed sore. So when you will make some distraction and improvement of the deformity by using external fixation, you will create best conditions for closing of the wound.
So effectively, if it is a deformity of, for example, a kyphotic deformity with a pressure sore at the apex of the deformity, once you correct, then it's not for a patient who has a sacral sore and a deformity in the thoracic spine.
Yes, unfortunately, I didn't show these patients in my presentation, but we have a lot of patients with bad sores of sacrum, of other localizations, and we widely use external fixation to create the best conditions for closing of these wounds. At first debridement, then putting external fixation and hanging them with this external fixator to create the best conditions for closing bed sores. We have a lot of experience in this, and a special septic department which is specialized in these patients, in septic spine patients.
I think one factor is that the external fixator doesn't allow the skin to contact to any surface, so that there is no more friction.
Yes,
that creates a bigger and better atmosphere for healing.
It's another side which is very important too. But anyway, when you're creating the best condition, you're decreasing the level of deformity. The skin is going from all parts to this place, and no problem. It will close very quickly.
May I ask another question?
Yeah.
So another thing is these external fixation devices, they are going to be proud and out of the skin. So how comfortable are the patients lying down? What about nursing? How difficult is it? Because deformity, and what is the duration for which these would be on? Because that would make a difference.
So the main rule is to be quick in replacing it. So it's the first rule, but sometimes it's impossible. For holopelvic system, you can really use it for a big period of time, but of course, especially for little children, it's very uncomfortable. So first of all, you must have very strict indications. So it's a safe boat, nothing else. If you can't do it in another way, use external fixator. If you can avoid it, avoid it. But if you can't, like in these cases, do it and try to replace it very quickly. So as usually for external fixator, for example, for huge scoliosis or scoliosis with neurological deficit, when we are not sure that it will be okay during the surgery treatment with his neurological deficit. So we use it for 1 week, 2 weeks maximum. 2 weeks maximum. So it's usually, if you want to change this, then the hardware to internal fixation, 2 weeks is enough. In 2 weeks you can solve all the problems. But in the conditions of bed sore, so it may be a little bit more, but you will not go to the same point of installation of hardware. So we use here pelvic, and then we will try to find another points for our screws.
So you'll change the anchor points.
Of course.
But I mean, how soon would you be distracting to correct? Like you said in scoliosis, I mean, it might take a little longer time.
As usually 2 weeks. 2 weeks.
So you would do a differential distraction every day, 3-4 times, the same way as for a regular LS drop?
And looking for neurological deficit first of all.
And what would be your end point of distraction at any given point of time?
It really depends. So as usually the main principle is the patient's pain, yes, and neurological lesions. So it's
you would be worried about these being osteoporotic pedicles, where if you distract too much, the pedicle may break and cause root or dural tears.
It's possible. Sometimes we seen the breakage of screws. Sometimes we had pain. So anyway, but it's a safe boat. You can use it only in very, very bad conditions and in very severe patients.
Yeah,
it's possible when you are using it promptly. When the points are very good, so it's possible, really.
So actually we are using this technique for last 5 years, and now the instruments are manufactured in India. और जो लेटने का है तो 4 इंच के 2 गद्दे ले लेते हैं हम लोग, उसको मिला देते हैं और उसका उतना स्लॉट काट देते हैं. Second thing, we are using this for 6 to 8 weeks. Even we are using this fixator into the disc, interrollable disc, spondylolisthesis, scoliosis. So in our 25 cases, only one case got an infection. They have to take bath every day, and that was cured by curating and other things. So I don't think we have great chance of the infection in our country. So our main indication is the spondylolisthesis, scoliosis, and it's very good in the disc. We like 4 screws, we distract that. Due to distraction, there is increased vascularity. We have this studied in the T2 image. After that and before that, the main advantage is as soon as we distract 1 to 2 millimeter of the distraction, so immediately the patient get relief of the pain, and gradually there is a hydration takes place in the disc. T2 image gradually become white, so it is a good indication.
Okay, and once again, septic conditions.
No, yeah. The main indication which I have told you, which they are telling that, for example, you have applied implant for fixation of the spine. For example, if it get infected, we have no choice. So what we do, we take the external fixator 2 vertebra above and 2 vertebra below, and then we apply the fixator, and then we remove all the implants there. So that is very good technique, indication for that. Yes, sir, you want to this? So,
Thank you.
no, thank you very much, Dr. Govind. Our next is the Dr. Dimitri. We will speak on the treatment of osteomyelitis of long bone using Ilizarov technique.
Okay. Dear colleagues, a lot of patients with pseudoarthrosis and defects of tibia and femur complicated with osteomyelitis has been treated in Ilizarov Center. Positive result in 98.1%. In most cases, the processes of pseudoarthrosis formation under purulent infection is accompanied by bone loss at the ends or fragments and by anatomical limb shortening of 1 degree or other. As a matter of fact, we deal with an acute bone defect, thus in the called pseudoarthrosis by us. Defects classification, defects pseudoarthrosis, defect diastasis. Each classification should reflect the main things of disease and contribute to a physical in selection of the optimal tactics and technologies of restorative treatment in every specific clinical case. The main task of restorative treatment of patients with pseudoarthrosis and defects complicated by osteomyelitis are stability elimination of the focus of chronic purulent infection, maximal anatomical and functional restoration as possible. Problem change slide. Не идет. Thank you. Thank you. The system of reconstructive and restorative treatment of the patient with long bone defects by Ilizarov is based on the following principles to rehabilitation approach: fragment lengthening, healing in the docking site, tibial fibural synostosis, and gradual tension of interfragmental tissues with regenerate formation. Classification of osteomyelitis basic technologies according to Ilizarov is represented on the slide. The scheme of monofocal transosseous osteosynthesis. Patient's diagnosis with pseudoarthrosis of femur, intermediary locking nail, osteomyelitis, 50 cm shortening, fistulography. Sequestral necroectomy, fragments adaptation, fixation using the Ilizarov apparatus. Short-term follow-up, fistula closed, integrity of the bone was restored. The scheme of the bifocal transosseous osteosynthesis. Patient's diagnosis with tibial pseudoarthrosis, osteomyelitis. Sequestral necroectomy of tibial fragments, fixation using Ilizarov. Defect was substituted with lengthening of the proximal fragment of tibia. Short-term follow-up, no fistula, integrity of the bone was restored. The schemes of the polyfocal transosseous osteosynthesis. Patients diagnosed with pseudoarthrosis of the femur, intermediary nail, osteomyelitis. 40 centimeters, 15 centimeters of shortening. True defect is 20 centimeters. Fistulography. Senation surgery with fragments, sequestral necrectomy, and fixation of femur of tibia using Elizarov apparatus. The scheme of femoral tibia synostosis, lengthening of the femoral and tibial fragments. Anatomical shortening was patellary reducted. Short-term follow-up, no fistula, limb integrity was restored. The scheme of tibial reconstruction using fibula. Patient's diagnosis with pseudarthrosis of tibia osteomyelitis, fistulography. Sequestral necrectomy of tibial fragments and fixation of tibia using Elizarov apparatus. Reconstruction of tibia using fibula. 1.5 years follow-up, no fistula, bone integrity was restored. Fibula is hypertrophied. Conclusion. Elizarov method is highly effective in treatment of patients with pseudarthrosis and defects of tibia and femur complicated with osteomyelitis. Thank you for your attention.
Any question? So my question is that how you transfer the fibula? Do you cut both the ends together, then transfer? And that acute docking.
Вам придется помочь, потому что я буду плохо отвечать.
Yeah, there is a fibula
Translation only.
Yeah, fibula transfer. How we do acute docking or gradually?
Одномоментно производим смещение.
Особенностью является дозированное перемещение.
So the solution is step-by-step transposition of fibula into the site of tibia.
Это принципиальное отличие от операции модификации гана, когда это производится одномоментно.
So it's the principal difference between our procedure and GAN surgery.
В чем преимущество? Преимущество в снижении рисков ангиотрофических расстройств при дозированном перемещении.
So our advantages of our procedure is the very low risk of problems with blood supply to the regenerate to callus.
Это особенно актуально, когда проблемные мягкие ткани.
So it's quite actual, especially actual where you have problems with soft tissue.
So now my question is that you take the fibula acute docking or you take
No,
it gradually?
step by step, by distraction osteogenesis, transforming it, getting it to the site of tibula, to the gap.
At the rate of 1 millimeter per day?
Yeah, the same.
Second question. When the fibula reaches there, how you fix the fibula to the tibia with some screw, something?
Когда достигает позиции правильной, фиксация.
Достаточно первичного сращения костного, а потом хорошая ортодизация.
Дополнительных винтов ничего нет такого. So we use only external frame for the primary fusion, and then good orthoses are quite satisfied for the patient.
Okay. Thank you very much. Now I request to Dr. Sergey a talk on the spinal osteotomies.
Okay. Thank you. Dear colleagues, a few words about spine osteotomics. General questions is vertebraectomy, is aggression or necessity. Indication, mobility increase in rigid deformities, restoration on the sagittal and frontal balance of the spine, decompression around the dural sacs and the spinal cord. The nosological groups is deformity of any etiology with the very huge deformity, more than 70, 100 degrees, severe trauma, oncology, degenerative disease with sagittal imbalance. There are 3 general variants of vertebraotomy based on the 3-column system. Total vertebraotomy, for example, pedicle subtraction osteotomy, asymmetric PSO, pedicular spondylectomy, axial procedure, bone-disc-bone osteotomy, extra pleural interbody vertebraotomy, and total and block spondylectomy. It's variant of TES, the cancellation osteotomy. Only enteral vertebraotomy, discectomy, enteral multilevel release, wedge-shaped discectomy, and variants of posterior vertebraotomy, for example, Smith-Peterson osteotomy. In deformity, we used PSO, asymmetric PSO, pedicular spondylectomy, axial procedure, bone-disc-bone osteotomy, variants of TIS, discectomy, and osteotomy of Smith-Peterson. PSO, the pedicle subtraction osteotomy, advantage local congenital or degenerative kyphosis, correction up to 13 degrees, and in the cases of kyphoscoliosis we used asymmetric PSO. Disadvantages: risk of neurological disorder, adjusted kyphosis, and iatrogenic canal stenosis. For example, the male 10 years old congenitally kyphosis due to combined to posterior non-segmented bar with vertebra posterior hemivertebra of L2 and block of anterior parts of L1, L3. We used only PSO technique, remove of the malvertebra around of dural sac, how you see, and shortening with shortening of posterior side of vertebra with correction deformity. X-ray after operation, good correction of sagittal and frontal imbalance. CT control with good contact with L1 or L3 vertebra. Post-traumatic deformity, PSO procedure, good sagittal balance. Asymmetric PSO we used with combined severe deformity, for example, thyroid cord syndromes, and how I see Arnold-Curry syndromes. We don't use correction with destruction. We use technique compression of the external side of the curve. We used classical CD instrumentation, asymmetric PSO on the apex of deformity, shortening the curvature of the external side, good correction, frontal and sagittal plane. Axial procedure, advantage, it's usually deformity with hemivertebra. Disadvantage, preserved asymmetric epiphyseal growth. It's simple procedure, only posterior approach. For example, congenital scoliosis due to non-segmented hemivertebra of L4. We use remove of all maldevelopment vertebra and correction on sagittal and frontal imbalance. The picture, for example, combine multiple maldevelopment. We use this technique on several level. Upper, it's a split, asymmetric split vertebra, and scoliosis deformity due to asymmetric hemivertebra. We used technique resection all multiple maldevelopment vertebra, acute pedicle resection, and correction of deformity in one stage. Good correction on sagittal and frontal imbalance. Pedicle spondylectomy advantage, congenital kyphosis and kyphoscoliosis with correction up to 45 degrees. Trauma, out type A3, C3. Disadvantage, it's the same high risk of neurological disorders and the iatrogenic stenosis of the spinal canal. For example, the young male fracture of T12 with dislocation of T11, type O C3. We used remove on this technique, shortening of the vertebra in thorax at lumbar spine. And fixation, use the CD system and bone plastic fusion. Bone disc bone osteotomy, it's technique of posterior 3 columns verge resection. General advantage, osteomyelitis, non-specific or tuberculosis. Trauma, out type C1, C2, disadvantage is the same. The male, spondylodicitis, L4, L5, by using debridement on the posterior approach, this bone osteotomy through the pedicle arch, and anterior fusion with mesh and the posterior CD fusion. Smith-Peterson osteotomy, disadvantage extended of local degenerative kyphosis, correction up to 30 degrees, kyphosis of Sherman's or Lindemann's, kyphoscoliosis. We use combined technique with anterior vertebrotomy with anterior approach. Disadvantage, it's the same, and it's not many cases device we had little bit device instability. Vertebral columnar resection, and it's the same name. It's total and block spondylectomy. Advantage, severe symmetrical frontal, sagittal, and translation deformity. This technique up to correction up to 17 degrees. Of course, tumors with improvement of all columns and perspective prognosis. Disadvantage, it's the same high risk of neurological disorders, high risk of massive blood loss, fixation instability, and pseudoarthrosis. For example, very severe post-traumatic deformity, lower paraplegia, consequences of explosive fracture of T12 or dislocation of T11. We used shortening vertebrotomy by VCR. This patient can I see good frontal and sagittal balance, and the patient is able to sit after operation. It's another case, severe kyphosis due to myelocele. We had two most problem of severe deformity, neurological problem, and problem of soft tissue. It's usual is bed sore on the apex of deformity. We use combined technique, shortening vertebrotomy, and correction of deformity in one stage with pelvis fusion. The cancellation osteotomy, it's variants of vertebral columnar resection. It's a first stage, removed of all pathological bones of apex of deformity, and secondary stage reclination and contraction on the posterior column. For example, very huge congenital progressive kyphoscoliosis. We used technique of the cancellation of osteotomy and good correction of the frontal and sagittal balance, how I see. Extrapleural interbody vertebrotomy, the preference and advantage, severe asymmetric frontal, sagittal, and translation deformity, and disadvantage, it's the same. We use this technique in combination of vertebrotomy variants and posterior and anterior release. For example, the young male, most severe idiopathic kyphoscoliosis, Lanky type 3C minus, huge ventilation deficit. First stage, we used combination of anterior multi-level vertebrotomy, how we see, and use external fixation device. After them, we used distraction step by step in other day. And secondary stage, we used osteotomy posterior by Smith-Peterson, correction and posterior instrumentation by CD, fixation. Osteotomy of the spine is a good method of spine mobilization. Vertebrotomy techniques range by the level of progression and outcome of correction. Vertebrotomy approach is to be reasonable, consider it in indication and complication risk. Thank you for your attention very much.
Yeah, the topic is open for the discussion. Any questions you want? So, Dr. Sergey, how you when there's one case where there was a bust fracture of the vertebra? Can you read back how you have corrected that?
It's this
No,
cases-
this back. Yeah, this
Yeah.
case. So, how you have done that? How?
It's severe spinal cord injury, and big problem. The patient was not able to sit after operation, lower paraplegia and function of disorder of pelvic organs. We use technique removed pathology, fracture of vertebra through the arch of vertebra. We remove posterior side, posterior column, and through the arch of vertebra, remove on bones and отломки, fragments of fracture. After then, we use shortening on the nails, on the rods, shortening on the rods, on the posterior system, with anterior and posterior bone plastic fusion.
Any questions? And how you have done the Smith-Peterson osteotomy first in the kyphosis case? Just show us.
Yeah, it's
Show the
typical
slide.
situation, degenerative.
Show the slide here.
Yeah. Only it's usually I use this technique with combine with anterior multi-level, looks
Yeah.
like this, anterior multi-level vertebrotomy, and after that using external fixation device. As a final stage of operation, we usually used Smith-Peterson multi-level osteotomy on the apex of deformity and correction by CD with derotation and compression of the internal side of deformity and compression of opposite side, external side of curve.
Basically what they do, I work in that, first of all, they applied the external fixator, whether it is a kyphosis, scoliosis. When they reduce that, if it is too much, they do the Smith-Peterson osteotomy and then internal fixation. If the deformity is not very acute, just they correct the deformity for the external fixator and then you put the internal fixation. That is the technique.
Yeah.
I think it's a very good technique. We are working a lot for that. You show the pins where you put the pins.
Put
Show the pins, yeah.
by external fixation. Yeah. It's pedicle screw, it's shunt screw.
You show the diagram of that. Shanspuri.
Shunt screw.
You have any diagram? Or you
Usually in the pedicles, no other visualization, only in the pedicles.
can you show any diagram of that?
It's another
Another lecture.
Yeah.
We tried this in about 12 patients. This was about 6 or 7 years before, and somehow we did not get very good results. The corrections that we got was not very good. So that's why. How much correction did you achieve by external fixator, and how much you got by doing a internal surgery? I mean, for example, if you have a 100-degree curve, in a series where you had not used external fixator, what was your correction and how much this technique really helped you to get better?
I used this combined technique only was deformity more biggest than 90 degrees.
Yeah.
Yes, it's enough. But it's usual. I used in deformity of 16, 60, 17, 13 degrees. It's usually only veins of vertebrotomy, anterior realize. It's usually it's them. I use posterior osteotomy and only interior correction deformity of internal fixator.
Yeah, you can handle.
Because
How much? He asked
one-
how much deformity you can
One
correct.
more difficulty we had was this was okay when we are using it for curves up
Yeah,
till
good
90, 100. But when you go to 120, it is not a scoliosis. It's always a severe kyphoscoliosis, and there was a severe rotational problem. And you did not know where to and how to put these angles, where you put the fulcrum. And in most of these cases where we tried beyond 120 degrees curve, these curves have got 120 degrees of scoliosis and about 80 degrees of kyphosis, or either way. And if you are putting a fulcrum all posterior to the spine, there was a certain problem that you could not correct it very well, because whatever distraction you are doing needs also a correction now at kyphosis, since you have also done a lot of anterior release. And then that means the fulcrum should go to anterior side, but all your pins are on posterior side. So we did try this technique, but we couldn't succeed. That's why I was asking. It became too complex when the deformity.
Yeah, if you want to see, they can see the slides in your previous slide. Yeah.
It's only one adding what I want to do. So first of all, the external device in our cases, in our institution need very strict indications. And these indications are not the amount of, not the severity of curve. The main indication is neurological deficit or danger of neurological deficit. So it's like a testing device. So we don't do this if we have a very huge deformity, but if we have some danger. So it's safety procedure. We try to understand if we'll get some neurological deficit, because if if you are using electrocontrol, electromyography during your procedure, or even wake-up test, you can be really sure that everything will be perfect in the future after emergency, intensive therapy, yes. So anyway, if you are not sure, if you have some troubles about what will be with the neurological deficit, you will use external fixator, not to make the curve more free, because anyway you're using verterotomies, but to test, to understand if everything is going right or wrong. Only this indication. So they are quite rare indications.
Can you show me the slides in your previous class?
Till what time you will distract?
Can you show me your slide, please?
So I showed it in the previous lecture. So
Yeah, previous lecture.
Previous lecture. 1 week, 2 weeks maximum. Big week to replace it. Big week. And of course, it's a big problem with positioning of the screws. Anyway, we control this with CT after surgery. But of course, you can put the pins only, the screws only in well-positioned vertebra, not on the in the mal-rotated or greatly rotated vertebra. So you can put them only in upper, like here, in a down vertebra. Or sometimes we use hybrids of holopelvic, or if you can use transpedicular, you can use holopelvic system.
Any question, please? If you are interested to see the slides, how they put that, they can. Please give me your first lecture so that.
It's in the computer.
Okay. Okay. Thank you very much. Yeah. Next paper is. This session is over.
This one.
Good afternoon, and I'd like to start this session by inviting Dr. Rajshekharan to give his first talk. I invite Dr. Rajshekharan.
Thank you, Dr. Das. After that very challenging series of cases that were shown in the last lecture, this is just because I was told it's an instructional type of lecture, just touching upon a few important points on some controversies and telling which is more important. Now, whenever we see a patient like this, our mind races to these important aims that we should restore stability, preserve and improve neurological function, relieve pain, restore spinal alignment, and prevent progression of deformity. And we all have been taught that the best way to do it is by surgery. But the most important thing is in the casualty setting and also when the patient comes to the ward, we should not look at stabilization immediately, because this is one common problem that happens all the time. And even in a busy spine unit like ours, every year there is at least 1 or 2 major misses where we have missed associated injuries. We have to remember that 21% of these injuries are missed in spinal column injuries, and this case illustrates the point. Now, this patient came to us with a translation, a type C injury, which we all know needs stabilization. He also had an open injury of the femur, which was also another distractive point. And can somebody see something wrong here? Anybody? Yeah, that's very important. So this guy was intubated immediately on arrival because he was in shock, and then operated. And this was done, this is long ago, but then the patient was not being able to be extubated because his saturation was falling all the time. And a repeat chest x-ray, you can see a review shows that he has got a huge diaphragmatic hernia. So your surgery doesn't have any much value if you are not looking at the patient as a whole. Now, the second important point is that you need a very careful documentation of neurology, because on the second and third day, you really have to know whether the patient is stable or getting worse or getting better. And you have no way of doing this if your first day documentation of neurology is not very clear. You might on your rounds find that the patient's attender says that he is slightly better or slightly worse today morning, and then where do you compare if you have not had a perfect documentation over there? And this is very important, and this chart must form a part of your this thing, and make sure that this is filled up before your surgery is done. Third, don't rush to surgery. Secondary neurological deterioration occurs more often due to physiological insults than secondary mechanical insult. I mean, I would request all the younger surgeons to read this once again. Secondary neurological deterioration occurs more often due to physiological insults than secondary mechanical insult. Now, these physiological insults are hypoxia, hypotension, hypothermia, and electrolyte imbalances. Now, how often do we really look into these very carefully when the patient arrives and when they come into the operating theaters? And if he has a physiological death of the spinal cord, no amount of surgery is going to bring back that cord alive. And this is again an important study which actually showed, they compared 2 groups, one which got operated and the other one without surgery, but they were all put into ICU, and they had resuscitation principles of volume expansion, they had good IV pressures, their blood pressure was kept high, and at the end of 1 year, 92% of cervical and 88% of thoracic incomplete injuries showed some improvement, and this was better than the group that had undergone surgery. So what it actually proves is that restoring physiology to the spinal cord is more important than what we always concentrate on, just fixing the spine. What about neuroprotection? How many of us give steroids? Now, if you have a fracture at T8 and the patient is paraplegic on arrival, 3 hours since injury, how many of us would give steroids? Anybody? How many would give steroids? Nobody? Oh, I think we have reached a saturation point of talking against steroids. Well, I fully agree that if you have a non-cervical injury, then absolutely there is no point in giving steroids. So you should not give neuroprotection, because although there is a large volume of theory behind it, the NACI 2 and 3 studies have demonstrated no sustained benefit of giving steroids in these people. And you are also giving a huge amount of steroid, 2 times higher rate of severe pneumonia, 4 times higher grade of severe sepsis, and 6 times higher incidence of death. So you are looking at a very marginal benefit, a doubtful benefit that does not sustain over a period of 3 months. And in the bargain, you are putting these patients to so much of risk over here. So subsequent to the NACI studies, you find that all clinical trials have not been able to prove a sustained good benefit of steroids. So the fourth important question, surgical stabilization, who needs surgery and when? Now the whole question again then goes to, are classifications useful at all in guiding us as to who needs surgery or not? Now the AO classification, which is used widely, I think there is no major problem in these groups. You know that this is very unstable, it needs, if it is just a small compression fracture, it doesn't need. Also chance fractures require. But the whole question is in the burst fractures. Are you able to clearly define which are unstable burst and which are stable burst? Now the 3-column concept was promoted by Dennis, and he brought the important concept of the middle column, an injury to which almost signified a problem, and he said whenever there was a problem with the posterior column, posterior wall, which means that your middle column is gone, then these people can have a major problem. But however, every study which has looked critically into this factor has proved otherwise, and they have shown that middle column break, just a middle column break in a CT scan is not an indication for surgery. So you are also having many other papers which promote the Cobb angle, the anterior body collapse, and also many definitions of unstable burst fracture. But this is commonly accepted. Anybody who has a progressive neurological deficit, but I'll tell you, in our practice of the last 10 years, I can recall only 2 persons who actually came into the hospital and then we noticed a progressive neurological deficit. This is much talked about, but if you are looking after them carefully, you are not throwing down them from the stretcher to stretcher or doing something very funny. This is very, very rare. If you have an increased 30 degrees kyphosis in the presence of neurological deficit, or a 50% greater loss of vertebral height, or your load sharing classification is greater than 7, then of course, then these signify that the patient may get an increasing kyphosis or instability, and they are talked about this thing. I won't go into the load sharing classification because all of you know that a correct position of 7, a point increase than 7 is indicative of surgery. Now we have actually proposed this AO spine trauma classification. There are some good things in it and some controversial things in it. We are just looking at more and more into how to refine it over the system. Now the last 2 controversies, is canal compromise an indication for surgery? Now how many think this is an indication for surgery? Nobody? Only one hand, I am seeing 2. Oh, now it becomes, okay. Now this actually is a question that can be split into 2. What do you think of the canal compromise when the neurology is normal and when the neurology is positive? Now if the patient is neurologically normal, then we know that whatever is the compromise, it is not hurting the dura, and so there is a question whether you need surgery at all. And if it is positive also, it means that this problem happened at the time of the accident, and so by decompressing now, are you going to make it better? Now traditionally it was thought that if you have a fragment inside the canal, and if it is more than 25% of canal compromise, you really need to do an anterior surgery and remove the whole fragment and decompress the canal. But this was included, and then many of the series showed that there is a large amount of complications associated with this. Now there is a very good article from one of the good units in our country, from Manipal, where they asked this question: does neurological recovery in thoracolumbar and lumbar burst fractures depend on the extent of canal compromise? Now they found that the mean canal compromise with deficit was 46, without deficit was 36%, with neurological recovery was 46%, without neurological recovery was 48%, and so there was no statistically significant principle between these two. And they said there is no big advantage they could find by doing a massive surgery to decompress the canal. Furthermore, they also found that when you have a compromise in the canal, your follow-up CTs after 6 to 8 months shows a normal reconstitution of the canal. So this is not an indication, but if you feel that there is too much of instability associated with the canal compromise, then surgery will have to be done to restore both. Now this is a reviewed 275 articles meta-analysis published by Bob Dixon and his group, and they also said the same thing. Paralysis occurs at the moment of injury, and decompression does not alter neurological outcome, and surgery may be recommended only for pain and other structural reasons. Lastly, is there a role for emergency surgery? Does it matter? Does it improve results? And is it safe? Now again, although we think that it's important to operate as soon as possible, all the prospective controlled clinical trials have not shown a major improvement or a major benefit by operating in the middle of the night. In fact, it has shown that when you do it very fast, unlike in the lab conditions, but in the clinical conditions, you have to operate only when there is a progressive neurological deterioration and a spinal dislocation with incomplete neurological deficit. Otherwise, all other patients can be operated the next day morning. So what is the lesson? Frank dislocations and translations require stabilization, and fusion as pseudoarthrosis can give pain and increasing deformity. But the vast majority of burst fractures, conservative therapy matches surgical intervention without the risk of increasing the complications due to surgery. So these are all the situations where you really need to operate. But other than that, if your setup is not so good enough, or if you are not confident that you can give good results, then you can do a very good conservative therapy. Anterior, posterior or combined surgery, if you decide to operate, we don't do anterior decompression at all. It's more than 15 years since we have done any anterior decompression for spinal fractures. Short segment fusion alone, if you do just one segment above and one segment below, is a problem because you can get bending of the screws and fracture. But we use this technique of including the fractured vertebra with a short screw on both sides, and this also gives you a chance to correct the deformity. We don't distract and try to bring the fractured vertebra back to normal height, which means that it will increase the porosity of the body. We accept whatever we get when the patient is lying prone, and after we have used this technique, our results have been far, far better, and there has been no need to go in on the anterior side. So anterior surgery is only for persistent major canal compromise, which is after your posterior surgery. So the learning point is surgery is an important but a small event in the overall management of the patient, and we really need to stabilize the cord, stabilize the patient's physiology before we think of surgically stabilizing the patient. Thank you very much for your listening.
We will take in some questions if there are any.
Yes, sir.
So, sir, surgery doesn't really affect the neurological outcome. Do we take that question?
Yeah. It's a very tricky question to put a blanket statement that surgery does not improve. You have to look at the fact that in the vast majority of patients, doing an emergency surgery on arrival in the middle of the night does not carry as much of benefit as we thought before. What the patient requires in the middle of the night is physiological stabilization, prevent hypothermia, make his electrolyte balance normal, give him good fluids, keep his blood pressure very high, and there is no harm of doing the surgery the next day morning. In all controlled studies, the improvement in operated patients is just the same as patients who are not operated. But would you like to keep your patient on bed without operation? That's for other reasons we operate, but not for, what I mean is don't convince the patient for surgery, bringing neurological improvement into one point of discussion. In fact, the fact will be you should say we are operating, but this may not help neurological improvement.
The role of steroid is controversial. So, what do you recommend for SCI and steroids?
In our institution, we have stopped using steroids long ago. Because if you read the NACI 2 and 3 trials, their benefit is a marginal improvement by 1 grade in 1 level, which did not sustain after 3 months. So if you had a C6 injury, so your deterioration either at C5, involvement, progression, or your power at C6 was by 1 grade different, improving over people who did not receive steroids. But this improvement or the advantage did not last after 12 weeks. So it's a problem, isn't it? You're giving a very high dose of steroid and putting the patient into risk. But this is totally irrelevant when you come for thoracic injuries, because 1 level between T6 and T7 doesn't matter anything at all. Thoracic injuries, thoracic spinal fractures also have a high incidence of chest injuries. And giving a very high dose of steroid puts them at risk for pneumonia and chest complications and infections at a higher level. So we are not giving steroids. Gastrointestinal bleeding, so many other issues are there.
Do you combine posterior decompression with screw fixations or just?
If you decompress for any condition, you have to stabilize. Especially if you are doing posterior decompression, that means you are removing the lamina. No, there is, if at all, in all these controversies, if I can say there is no